Thank you for that introduction. Can I have my first slide, please?
Thanks, Stefan. Right here.
So while we're waiting, I'm going to be a bit tongue-in-cheek here. So please bear with me because I'm going to give you sort of a little bit of a personal view of obesity because I've been given a title of Waste No Time. So hopefully I won't waste your time. So here's the story. There's this house on fire. There's a patient waiting outside who owns the house. She's talking to her physician, and a nosy neighbor comes along, who's the obesity physician, and asks, "What's going on? Haven't you called the fire brigade?" The patient says, "I'm waiting for the alarm to go off." The doctor says, "I'm waiting for the alarm to go off." And this is how we treat obesity. We're waiting for something bad to happen before we tackle obesity. We wait for diabetes to occur, and we say, actually, we need to tackle the weight. But what we need to know is the underlying problem, which is obesity, that's contributing to diabetes. So we're mainly reactive in our care, so we need to be more proactive. And also, we need to recognize that obesity is a chronic disease. If we don't manage it well, we're not going to succeed. So here comes eventually this doctor comes along, this physician, and says to the patient, "Look, your house is on fire. Now I'm going to help you sort it out, but it's your fault. You're responsible for this. You used your heating too much. Uh, Stop using it. That's your food. Stop eating it. Stop heating your house. Stop using the wood. You're using too much, so it's your fault. And disconnect from all the electricity and the gas. That will solve your problem. Disconnect from all the parties you go to, all the foods that's around you, all the social events. And if you want to put the fire out, every day you have to walk 5 to 6 kilometers to bring water back to put your fire out. Asking them to exercise is really hard to do. Just imagine somebody with a body mass index of 40 trying to undertake 150 minutes of physical activity every week. It's really hard. So our expectations are really high. And then, if you really want me to solve the problem, I'm going to bring this clinic to you, which is the fire engine. It's going to have a physician, a dietitian, a physiotherapist, and because you're so depressed now that your house is nearly burnt down, I'm going to bring a psychologist in to help you out. So let's look at this is one of the problems that we have in terms of physicians dealing with obesity. There's a delay in diagnosing obesity or helping people recognize or help with their obesity. And people with obesity people living with obesity do take the responsibility that they are responsible for their current state, but no one chooses to have obesity. So we need to recognize it early and give our patients advice, and our patients want us to guide them. But let me take you through this story because nobody, put your hand up, who chooses to have obesity? Anybody here? Let me tell you a story about Aisha. Aisha was born, her mother had gestational diabetes and obesity. There was no breastfeeding, which is protective of obesity. She gained weight as a child, so dietitians and pediatricians it couldn't really help. Her weight started increasing as she got older. She had bullying, depression, and when her period started, it was all irregular. Became short of breath because she was inactive. Went to GP, so dietitians, pediatricians, they couldn't really help. She grew up, did some shift work, had sleep deprivation, tried to lose weight on and off. Every time she lost weight, she lost some muscle with it. Every time she gained weight, it was mainly fat. So her muscle levels went down, which made her activity, physical activity, more difficult. Then she got married and became depressed. I don't know whether she got depressed because she got married, but that's a different story. But depression developed. She saw GPs, dietitians, commercial, and she couldn't get very success. Then she wanted to get pregnant. She had multiple miscarriages and eventually ended up having in vitro fertilization. And then she had gestational weight gain and she had gestational diabetes and hypertension. And eventually she ended up developing diabetes. Where the doctor came and said, "Look, your house is on fire. I'm waiting for the alarm to go off. Here's the alarm." And then she was also diagnosed with fatty liver and had uterine cancer, for which she needed a hysterectomy. And eventually retinopathy developed and stage renal disease. and ended up on dialysis, and ischemic heart disease goes with dialysis, and she needed a renal transplant. And the doctor said to her, you cannot have a renal transplant, your BMI is too high, and your daughter can't give you a renal transplant because her BMI is too high. So start discriminating against her because of body mass index. But what we have to realize is actually nobody chooses obesity, and obesity actually creeps up on people over the years. So you need to have one equivalent to one chocolate biscuit extra, which is about 100 calories every day, to put on 5 kilos in 1 year and 25 kilos in 25 years. So it's very small margins. But of course, people eat more than that. But eventually, this builds up on people, and they get to a stage where it's difficult to shift it. And when they try to lose weight or reduce their weight, what happens is your biology kicks in. So in a weight loss state, energy expenditure has gone down, and the appetite system is upregulated. So it's very difficult for people once they've had the stage of excess adiposity to actually try to turn this around. Of course, what we do is you're not trying hard enough, you're not exercising enough, you're eating the wrong foods, and all they're getting is the blame for it. So what we need to do, we need to change our thinking about the disease, because the chronic disease is really hard for people to change, and we need to give them that time. Somebody asked, how long do people need? As long as it takes to get them back on track in terms of what they need to do. And what we need to do is provide them a self-determination framework. Part of that is to give them autonomy. They need to have the feeling that they have a choice of what they're doing, give them the knowledge and the skills to be competent in what they do, and having a community to support them, instead of blaming them for what they do. So we now have all these diseases that are top diseases that are actually, in terms of mortality across the world, and what's contributed to this obesity, but everybody tends to ignore it. And it's estimated that 2 billion people by 2035 will have obesity. And of course, it contributes to ischemic heart disease, all these complications that you can see here. But we also need to think about things a little differently. We start initially by saying, oh, obesity, BMI, but actually it's not that. We have a complication here, like let's say fatty liver disease, for example, or ischemic heart disease. Is there an underlying adiposity problem that's driving this? And if there is, go look for it and think about treating the underlying condition. Hypertension, for example, is there an underlying adiposity problem that we need to look at rather than waiting, doing it the other way around? So what do doctors find it difficult when they try to manage obesity? Is they have no time. We are very much used to handling people with medication. Your blood pressure is X, I'm going to give you this drug. And see you in 3 months' time, and we can see what your blood pressure is doing. But actually changing somebody's diet, activity, sleep, psychology, behavior techniques takes time. So we need to build that time. And many doctors don't recognize as a disease. Why should I treat something that is not a disease? But actually, if you start, let's say, with somebody who you think has excess adiposity, you can find one of the 200 conditions, then call it a disease. So think about it. It is a disease. We'll talk about that in a bit. People are afraid of treatments. They think bariatric surgery is a really bad thing to do, but actually it's safer than a hip replacement or a cholecystectomy. And they feel that patients need to make effort, that patients are lazy. We always have this belief that they're not trying hard enough, but we don't put them in the context of what their lives are like. So they may be very busy, having young children, cannot afford food that's healthy. All these things come in. There are cultural challenges that were identified, and prevention is not a priority. As physicians, we need to consider the whole range of delivering health for individuals, including prevention. And part of our problem is weight stigma that is really around every practice I've been to, every place I've been to. I can see all that stigma happening. This negative attitudes, stereotyping, people with weight are lazy, sloppy, lack willpower. and there's bullying that occurs in children. So weight stigma is a really bad experience for those individuals. And what happens is you get into a vicious cycle where obesity results in health consequences and then increased medical visits. There's more stigma in healthcare. The patient goes and sees the orthopedic surgeon. I cannot operate on you. Your weight is too high. Go away. Nephrologist, you cannot have the transplant. Your weight is too high. Go away. I cannot do this for you. Go away. And this causes stigma and putting people in the back burner. So if they're not able to mobilize because they didn't have their knee operation, they're not going to succeed in the long term. So we need to start considering obesity as a complex, chronic, persistent, progressive, relapsing disease due to excess adiposity. Now think of your adipose tissue as a tissue. It can be a lot of it or it can be less of it. It's excess adiposity that results in health, psychological, and social consequences. Now, you might be aware of this Lancet Commission, where they define clinical obesity and preclinical obesity. And one of the first things they identified, actually, BMI is not a good measure. But they said clinical obesity, the reason they call it clinical obesity as the disease is because they want to prioritize healthcare. But actually, if you really want to look at those complications, obesity has contributed to some kind of end organ problem that needs to be addressed. And the problem we've had with obesity is BMI, because if you look at this data from the UK, if you take the white European at the BMI of 30, if you're South Asian, you're talking about a much, much lower BMI of 23.9 in terms of increasing your risk of diabetes. So BMI has been a really bad thing for addressing obesity. What we need to do is look at the problem. Is there an underlying adiposity? How can I measure it? BMI is one factor. DEXA scan is another factor. Bioimpedance, waist-height ratio. Having a waist-height ratio more than 0.5, more than a half, is a good measure. So how do we approach the patient? Identify there's a problem, then find how much there is excess fat, where is it, and how much of it there is. And you could use different measures. And as an endocrinologist, I'm happy to send people to have a DEXA scan to have for their bone density, but I don't send them for a DEXA scan for body composition. Why don't we do that? If we really think there's an underlying problem with adiposity, and I have patients with BMI of 24 who have very severe metabolic associated liver disease. I do a fibroscan, I do a DEXA scan, I do look for where that adiposity is and how I need to address it. And then we need to look at the cardiometabolic, psychological, and mechanical complication, and then we need to stage the disease. And we use the Edmonton staging system, which goes from where there's no evidence despite investigation of any issues, to a pre-disease state, to a disease state, to a more severe stage, where stage 4, we're talking of palliative type of care. Now, in the interest of time, I'm going to go through 2 patients quickly. This was a 35-year-old who had type 2 diabetes for 2 years, BMI 44. And he was enrolled in the Diadem study, which we did in Qatar. And the idea of Diadem was to take early diabetes and manage that through lifestyle intervention. And you can see that the group achieved very good weight loss in red compared to the control group. And most of it was fat mass and body muscle mass was preserved. About 1 in 5 achieved a weight loss of more than 15%, and 61% in the intention to treat analysis had diabetes, type 2 diabetes remission, and about 30% had normal glycemia. Now, we did see GMS in this individual before and after. This person see GMS before, and you can see after that we can achieve really good outcomes in terms of lifestyle intervention. This is another, so this is in 2 years, you can see the weight loss, the HbA1c is normal, and this person is now in diabetes remission. Here's another case, 27-year-old male who used to eat a lot of fast food, KFC, lots of Carac and lots of juices. And at the initial visit, we diagnosed him as newly type 2 diabetes, fatty liver was identified, insulin resistant vitamin D deficiency. And then we discussed goals with him, working as a multidisciplinary team. He started walking 30 minutes a day, and he was started on metformin and liraglutide. And of course, we have now better medications, and Dr. Wasim's going to talk about that. And this is the outcome. So he went from 128.5 kilos to 97.3. Just to point out, his BMI wasn't normal, although many of his parameters are normals and they've gone into diabetes remission. So don't expect your patients to become normal BMI even after bariatric surgery. So now we have really good interventions. So we got intensive lifestyle intervention, and pharmacotherapy and bariatric surgery. So we can really talk about our patients, about what they need to achieve. So find what the problem is. Is it glycemia? Is it type 2 diabetes? Is it dyslipidemia? Is there an underlying adiposity condition? How much weight do we need to reduce to be able to achieve good outcomes? And now we can give real targets to people in terms of what they need to do to achieve the outcomes that they want. So let's start having a different conversation with our patients. Think about what they're going through, avoid stigma, support them in terms of understanding their disease and how to manage it. Thank you.